will join. And he's joining us from Costa Rica, right? So he's extra committed to our population. We really appreciate you being here with us. Thank you so much.
My
I was
pleasure.
just
I'm looking at my photo. It's definitely more clean shaven there. I apologize. I'm in vacation mode.
that's awesome. That's great. Um, I wanted to first acknowledge something that's really very important for us to all sort of sit in, which is this for many of our families. I know I felt this way when somebody said, I think your child needs brain surgery. For us, it was removing half the brain. This is trauma. Um, what we see our children go through on a daily, weekly, monthly basis can rise to the level of a true medical trauma, what they're experiencing, perhaps what siblings are experiencing. And I really encourage all of you to really kind of take a deep breath and know that this can rise to that level of a true medical trauma. Seek help, whether it be from somebody close to you, someone in your religion, your church, or whatever it is that you do at the hospital. Ask for help, because all of the decisions that we make around our kids, all of the things that we see them go through can really be very traumatic experience. So I just wanted to sort of hold a mirror to that. I wish somebody had talked to me more about how traumatic all of this can be. Let's start with just an overview of what treatments for epilepsy are. Really, there are only three things that are treatments for epilepsy. There's medication. We're all very familiar with that. There's surgery, and there's diet. And so we're quite familiar with medication, quite some of us are familiar with diet, but really at the end of the day, we don't talk about surgery enough. We don't bring it kind of to the forefront when it's time. And that's what we're here to do. I want to talk about the chances of seizure control with medication. I don't know if many of you have heard of this, but with the first medication, almost half of children will be seizure free after trying it. With the second medication, another 13% will be seizure free. But really, that number drops way, way down to almost zero after the third medication. And the rest of the kids, my child, probably all of the kids of the parents that are watching this webinar, are what are called drug resistant. And we've known this test since 2010, when a really important publication came out. So the rule is, after your child has tried 2 anti-seizure medications that are appropriate, that are the right medication for the seizure type, and that are used in an appropriate manner, if the seizures are continuing, that's when you're supposed to be referred for a surgical evaluation. So it's after the second medication doesn't work. And there's a growing body of research that says if the child has cortical dysplasia, we really need to be thinking about referring them for surgical evaluation after one failed med, because kids with cortical dysplasia have a really, really high chance of having drug-resistant seizures. I think it's over 90%. So really, after 2 failed medications, it's time to start talking about epilepsy surgery, time to ask for that referral for what we call a comprehensive epilepsy surgery evaluation. I popped this slide in a few minutes ago. I think it's also really important for us to acknowledge that many times we're waiting for that next medication to come out. We feel like, researchers are always discovering new medication, and maybe that next med will be the magic silver bullet. Medications for epilepsy have been around since 1855 or so. We saw quite a few of them being developed in the 1930s, 40s through the 70s. There were the second generation of drugs that came out in the 30s through the 70s. And then what we call the third generation of drugs that have started to come out since like 1985, with this last one, I think it was 2021, fenfluramine. The rate of drug resistance is still the same. So we still see 1 out of 3 patients that are still medication resistant. So even though all of these medications continue to be discovered, that drug resistant rate stays the same. So the rule hasn't changed. If you're drug resistant, you're supposed to be referred for surgical evaluation. And the International League Against Epilepsy, which is this large body of experts that sort of sets these guidelines for doctors to follow has said that every patient, and I put this in red because notice that it doesn't say every patient over 5 years old or every patient over 1 year old. It says every patient. So that means infants, that means babies are supposed to be referred for surgical evaluation as soon as they're drug resistant. We've talked about what that means. That's failure of 2 drugs. And it doesn't matter whether you're wealthy and have a lot of money or don't. It doesn't matter the seizure type. It doesn't matter if it's a genetic type of epilepsy that's causing it or an epileptic encephalopathy, whether it's seizures starting from both sides of the brain. You're supposed to be referred for a surgical evaluation after failure of 2 appropriate and tolerated medications. That's the rule. Epilepsy surgery is not a last resort. And if you walk away with anything from my portion of this webinar, I want you to know that having a surgical evaluation does not mean that you have ultimately decided your child will have surgery. I know it feels really scary when doctors start talking about brain surgery or these devices that are used. You're not making the decision. You're getting more information when you ask for a surgical evaluation and have it, so that then you can make a decision that's based on data that you can take back and discuss with that team. So starting that process, going there, so to speak, we always hear parents say, I don't even want to go there. I don't even want to go to the brain surgery talk. Not really going there. You're getting more information, and you can't even really talk about it if you haven't had at least what's called a phase 1 surgical evaluation. Drug resistant, we're going to talk about some scary facts right now, but I think it's very important for us to really know this as parents. Drug resistant seizures are risky. They can cause cerebral dysfunction. So I think we've all seen it in our children, psychiatric, cognitive, or behavioral challenges. They can have slow development or regress. So you might see skills that are acquired and then they're lost when the seizures continue. They can have a reduction in brain volume. There's actually a paper that was just published a few weeks ago that shows that there is a reduction in brain volume if you've had years and years and years of seizures that are uncontrolled with medication. And just a few weeks, I think it was 2 weeks ago, a paper came out that showed that if you're having drug-resistant epilepsy, those seizures can be reinforced during sleep. So you're actually creating sort of strengthening that seizure network during sleep if the seizures continue. So drug-resistant seizures are bad, and we want to do everything we can to stop them. These are scary facts that I'd like you to know, but a really important paper came out in the Lancet 2 years ago. I blogged about it. You can go to our website and read it. It looked at the 10-year survival rate in children with medication-resistant seizures. So this is kids who are alive 10 years later. If the kids were having just medication, were taking just medication, 89% were still alive, meaning 11% had passed away. So 11 out of every 100 kids were no longer alive 10 years later. If they had a vagus nerve stimulator, 92% were still alive, but that number goes way up when you're looking at medication and cranial epilepsy surgery. And all those kids in that study that had brain surgery were not seizure-free, but many of them had a reduction in seizures, and we see that can improve their 10-year life expectancy. Looking at these facts a little differently, if you're treated with medication and cranial epilepsy surgery, you have an 83% less chance of dying. That is a huge statistic for us parents to understand, and a 35% less chance of dying if seizures are treated with a vagus nerve stimulator. And I know those facts are similar with responsive neurostimulation and deep brain stimulation. There is data to, for example, show that both of those devices can reduce the chances of sudden unexplained death in epilepsy as well. When you're talking to a surgeon about epilepsy surgery, when you're talking to the neurologist about phase 1 evaluations and what the data says, it's really important for you to understand what your end goal is, right? A lot of times we want no seizures. Of course, that's what we call these seizures are generally called curative seizures. I don't like using this terminology because it makes everything black and white. So that might be your goal. Your goal is what you, your family, your loved ones want for the child, or is your goal reducing seizures? I hate this word palliative because palliative to many of us, to most of us means giving up, right? I think of palliative as like hospice care or end of life. I hate that this word is used in our world. Palliative just means reducing seizures. So the procedure might not stop the seizures completely or make them all go away, but it may reduce the seizures enough to improve the child's quality of life. So a kid that's having 100 seizures a day and can't hold his head up, but if there's a reduction in seizures enough to give them head control, for example, so that they can eat by mouth or no longer be tube fed, I call that a huge win. This is a decision for you and your family to make when you're looking at these surgeries is what is your end goal? And I would really like you to step back and think about, the procedure may not stop the seizures completely, but is it going to improve the quality of life of my child? And many of these procedures will. All right, Dr. Stone, why don't you take it from here?
Thank you, Monika. It's an absolute pleasure to talk to everybody here, and hopefully this will be helpful, and we'll have time for questions at the end. As was mentioned, I'm an epilepsy surgeon. I work at Boston Children's Hospital, and my goal here today is to really just kind of give you a sense for the breadth, I guess, of epilepsy surgery. One thing that's really important to know is that, of course, what is applicable for your child or you is going to be very specific to you and your child. So, some of this was going to be things that may not be relevant. But I think what's really important to know is that there are a lot of options. It's not just a one, trick pony situation. There are many options nowadays that can be tailored to an individual to make sure that we are working towards achieving the goals that are appropriate for your child. So really, if you want to simplify things, there are 4 basic options we have, and of course within those there are subsets of sort of technical details. But really, there's resective surgeries. So this can easily kind of make sense. This is our sort of tried and true. If we have a specific focus in the brain that's the source of your seizures, and we can remove or eliminate that source, then we may be able to eliminate the seizures. So that's one. Resective in this sort of context means kind of a craniotomy. So, standard operation where you open up into the head and remove that part of the brain. The next category, called destructive, or some people say ablation, is kind of referring to the same thing in a way, but approaching it from a minimally invasive standpoint. And what's kind of depicted in that image there is the poster child for this nowadays, which is stereotactic laser ablation. The idea, again, is to eliminate an area in the brain, but to not have to do open cranial surgery, instead to insert minimally invasive laser fibers into the brain. And we'll talk a bit more about this. The next one is disconnection. So, the idea here is, what if you have a very large area of the brain that needs to be dealt with? Or what if you want to alter the connectivity or connections within the brain to improve the seizures? So that's kind of a disconnection surgery, which can be sometimes done minimally invasively, or more typically open surgery. And then finally, to stimulate or neuromodulate, as it's called. So what if we cannot safely remove a seizure focus? Or what if there is no specific seizure focus and we want to achieve a more broad influence on the brain? That's where neuromodulation, of which there are multiple types, the main ones being vagus nerve stimulation, deep brain stimulation, and responsive neurostimulation. I don't know if I have control here. Okay, there we go. So how do we access the brain for surgery? So again, the more traditional method is depicted in the somewhat scary image on the left there, which is open cranial surgery. And basically that means, making an incision, removing a window of the skull, going in, doing the operation, putting that window of skull back on, closing up the layers. In the middle, that's burr hole access. So this is a more minimally invasive approach. In the diagram here, there's a small access and an endoscope being inserted with micro instruments, which can sometimes be a less invasive way of dealing with the seizure focus. And then on the far right, you see more of a twist drill hole, so an even smaller opening and inserting a laser fiber into a deep target into the brain. So there are different ways we can get in, basically. Um, what are some common situations where resection may be opted for? These are just some MRI images of the brain. On the far left, you can see a lesion. This could be a tumor, for example, a low-grade tumor, or maybe a tangle of abnormal blood vessels, like a cavernous malformation. So you can see that blob kind of on the left side of the image right there, which may correlate with the seizures, and removal of which may eliminate the seizures. You can see in that second image, there's a white arrow pointing to a part of the brain, and you kind of may have to take my word for it here, but if you look at that, you may notice that it looks a little bit different. That area of gray looks a little bit larger, maybe a little bit smudged in terms of its sort of border with the brighter underlying white matter or connections underneath the surface of the brain. So that's, for example, a common finding when we have a congenital, something the child was born with, malformation like a dysplasia or other types of malformations of cortical development. In that third image from the left, you can see a red dotted circle outlining a lesion that's kind of right in the middle of the head. That looks very typical for a hypothalamic hamartoma, okay, another congenital lesion, which is a very common cause of seizures called gelastic seizures. Monika was mentioning that, for example, in focal cortical dysplasia, the field is moving towards earlier surgical treatment than, say, some other conditions. This is probably even the farthest extreme of that. A child with a hypothalamic hamartoma, medications tend to work so rarely, and surgery is so effective that we actually generally recommend surgery before even waiting to go through multiple medications. And then on the far right, this is an example of a child that's had a large stroke affecting the one side of the brain. So you can see on the one side, there are areas that look dark, kind of expanded. That's areas of the brain that died in the process of an injury. And in that case, you can see that the injury to that one side of the brain is so extensive that when seizures are coming from a very extensive injury to an entire hemisphere of the brain, then often what's called a hemispherectomy or hemispherotomy, which is basically removal or disconnection of the entire hemisphere, can be a curative treatment. So what can you resect? So there are many different diagnoses for which a resection may be appropriate. And again, some of these may mean something to you, some of them may not. And if they're not relevant to you, they're not relevant to you. So it's a good example of sort of the vast array of conditions that can present with epilepsy. So cortical dysplasia, a part of the brain cortex that did not form normally. The formation of the cortex is critical. The degree of electrical activity that's happening in your brain while we just live and think and do things is so complex that one little mistake, if you will, in the way that part of the brain formed can lead to a short circuit where some of those electrical signals are not controlled, and that can lead to epilepsy. A condition called mesial temporal sclerosis, which is a mouthful, often abbreviated to MTS. So this is a condition where the medial or mesial part of the temporal lobe has scarring, usually involving the hippocampus and amygdala. For those that may know what those are sort of mesial structures in the brain, very epileptogenic, and is a common condition for which we perform resection. Things like tumors. Tumor is a very loaded word in medicine, of course, and for good reason. Tumors in the brain, particularly in children, is a very different beast. Okay. There are many types of tumors that children get that are curable with resection, that don't really grow or don't spread in the body, like you may think of other types of tumors that we're aware of. And often they can present with seizures. I already mentioned cavernous malformation. So this is a sort of abnormal blood vessel lesion in the brain. Rasmussen's encephalitis. This is a condition of sort of autoimmune inflammation that attacks typically one hemisphere of the brain, and is very, very common cause for epilepsy and is often treated with a hemispherotomy or hemispherectomy. Hemimegalencephaly is a condition where really one half of the brain or one hemisphere forms abnormally. It is abnormally large, dysfunctional, and often causes seizures. And again, a hemispherotomy or hemispherectomy is often a treatment there. Sturge-Weber syndrome. This is another condition where children have an abnormal blood vessel problem affecting a large portion of the brain. It's often, say, an entire lobe or entire hemisphere, and very high rates of drug-resistant epilepsy, and a relatively common indication for lobar surgery or hemispherotomy, for example. On the right list there, tuberous sclerosis, another condition. Many of these, like Sturge-Weber, have skin manifestations to these conditions. So they're often called neurocutaneous syndromes. In other words, neurobrain and cutaneous skin. But tuberous sclerosis is a condition that can affect the brain, cause seizures, and often is focal or multifocal, necessitating surgery. Encephalomalacia, this is kind of a blanket term for a missing part of the brain, if you will. So the most common sort of thing we encounter here would be, say, a stroke, often suffered sort of perinatally, in other words, around the time of birth or even before birth, leading to damage to the brain and seizures. Sometimes we see it in the setting of trauma, where there's been a bad bruise or contusion in the brain, which then leaves sort of an empty cavity, and the edges of which can be very scarred and epileptic. And then finally, non-lesional focal epilepsy. So this really refers to epilepsy which can come from a focal part of the brain, but we just can't see it based on our current technology. So despite MRI scanners really finding so many lesions that we couldn't see even, say, 10 years ago, there are still some cases where we're able to establish that the seizures are coming from one spot in the brain, but we just can't actually see a lesion. And there are other steps we may need to take to try to identify where that seizure focus is and what we can do to target it. So that's a lot of talking about lesions and surgery, but what's the point? Well, this is really the point, and Monika was already touching on a lot of important points about this. This is a really interesting study. It's one that probably would not be possible in the United States, but this was actually done in India and published in the New England Journal of Medicine, where they randomized over 100 children. So these are kids under 18 years of age, to either epilepsy surgery or continued medication when they had drug-resistant epilepsy. The ones that were randomized to continued medication were actually put on a wait list, so they had to wait a year before their surgery. And the ones that were randomized to the surgical group had their surgery, right away. And when these kids were followed out 12 months later, you can see these incredible results. And it still almost amazes me, even though I'm in this field. But you can see that just lumping all of these kids together, the half that underwent surgery, 77% were seizure-free at 1 year, and only 4% of the medication-only children were seizure-free at 1 year. So a really dramatic change in outcome. So moving on to some specifics here, and laser ablation is often one that gets asked about because it's very powerful, minimally invasive technology. So what this involves is using heat essentially to destroy or ablate small areas of the brain. So in that diagram, you can see a small laser fiber. These are usually about 1.5 millimeters thick. And this is being passed through a small opening in the skull to a very precise location in the brain. Um, that looks like it's heading into the temporal lobe, probably an example of mesial temporal seizure focus. And by passing that in, you can target this area. And then um, really the breakthrough that enabled this was something called MR thermography, where once the laser is in place, the patient is actually put into an MRI scanner while they're still under anesthetic. And then you can live image heat in the brain with the MRI scanners nowadays. And you can sort of watch as you turn the laser on a little bit, make sure everything is happening okay. You warm things, you're happy. Then you can turn the laser up to an ablation temperature. And basically, it will heat and burn that part of the brain. You can do this in a controlled way. You can move the laser in and out. You may have multiple lasers to kind of contour an area or to target different regions. And once you're finished, you remove the laser, you close the little sort of stab incision in the skin or multiple incisions if there's multiple lasers, and then the patient will recover in hospital from that. So very minimally invasive, very elegant technology, and it does not require. One of the nice things is if you're trying to get to a deep part of the brain, with traditional surgery, you have to pick some avenue to get in. So sometimes that's helpful. If it's a large lesion and you want to do a big disconnection, then you actually need to do that extra work. But sometimes you would rather preserve that overlying brain, even if there is a quote unquote safe access pathway. It's still better to not disturb things as much as possible. The other thing is that it, of course, can make surgery less uncomfortable, and recovery times faster. And as we're learning more and more, shorter hospital stays, lower blood loss, lower risk of infection, things like this. Here are some pictures. So hope no one gets grossed out by any of these, but they're pretty tame. But you can see on those panels on the left, this is an example of a patient actually undergoing a corpus callosotomy. We'll talk about that a little bit in a second, but this is an operation designed to sever a major fiber bundle that runs between the two hemispheres of the brain. And that panel A, that's what's called a sagittal image of the brain. The nose is to the left, the back of the head is to the right. And those white arrows are sort of to represent laser trajectories that are designed to get to that sort of banana hooked shaped structure that the arrowheads are ending in. That's the corpus callosum. And the idea is to burn or ablate those fibers, which is what we can also do with open surgery. But in some cases, this can be done with a laser. And you can see on that panel B, the lasers are put in through very small stab incisions. Those are actually little kind of tubes or bolts that are going into the skull that the laser will pass through. In panel C on the left, you can see intraoperative imaging technology that we commonly use. In the foreground is actually a robot, so assisting in putting these in very precisely and minimizing human error. We do have a lot of technology that can help. And then on the panel on the far right, there are a few different, vendors out there. This is a Medtronic system. I can tell because I used to use it. But you can see that little kind of almost translucent fiber heading down into that blue tip of a bolt and that bolt going into the head. So very minimally invasive, because you can see here often requiring either no hair shaving or even just a minimal hair shave in the area. And you can pass that fiber into that target and then do the imaging, as I mentioned. So what are some other procedures that may not require, for example, traditional open surgery? On the far left, gamma knife radiosurgery. This is very old technology now, still used very commonly in neuro-oncology or for treating tumors primarily. But basically the idea here is to use radiation, and the way this works is you obviously don't want to just pass a lot of radiation through someone's brain. But if you pass multiple weak, very thin beams of radiation, and have them all coalesce on one point. So there's one focal point to all of those weak beams. You get very minimal exposure of radiation to the rest of the brain and very high radiation to the target where you want to ablate. So it's another way of ablating or lesioning part of the brain. We don't use this very much in children with epilepsy, outside of some, say, that have tumors, but that's more of a tumor-focused treatment than an epilepsy treatment. And the reason is that, even small amounts of radiation have a potentially important long-term consequence in a child who may live another 80 years. That gives them more time for, unfortunately, the risk of, say, a cancer or tumor forming. So it's something we tend not to use very often, in part also because we now have other technology that does not require radiation, like the laser, for example. In the middle is a newer method also that's being used in some cases. This is called an embolic hemispherectomy. And the idea here is that a hemispherectomy, where you disconnect one hemisphere of the brain, so that's hemispherectomy. Ectomy actually means removal. So in this case, removal. It's a big operation. And sometimes we need to do it in very young children, very small children. And there may be other medical factors to do with that child, such as lung disease or heart disease, that makes surgery like that high risk. Sometimes people will consider doing this where they actually purposefully cause a stroke to effectively eliminate that tissue when the child is very young. This can be done by feeding in little catheters through arteries, accessing them maybe in the groin region, in the arm, somewhere else in the body, feeding them up into the brain and occluding or blocking those vessels, causing that tissue to essentially die. And if the brain tissue dies, then the idea is that brain tissue that's causing the seizures can no longer trigger the seizures. So still, I would say, considered a little bit experimental, but is another example of where the field is moving in some cases. And then on the far right is new technology called focused ultrasound, has been used more in adults, more for lesioning very small parts of the brain, say in patients with a movement disorder or a tremor. But the idea here is a bit like that radiation I was explaining, where instead of radiation, you're actually sending multiple beams of sound waves that all coalesce on your target point and result in sort of a heating of that tissue from sound waves. So again, newer technology that doesn't even require, even a small hole in the brain, and is starting to be used in some cases in children now. So I mentioned corpus callosotomy earlier and disconnective surgery in general. And I think sometimes this is a confusing point for people. But basically, the field of disc, or the types of surgeries that we include in disconnective surgery, the poster child for this really would be a corpus callosotomy. And this image here is actually, and thank you, Monika, or whoever's doing that. This is a picture of a brain looking from the top and looking down. And you can see that big white kind of fiber bundle that is funneling into the interhemispheric or between hemisphere space and then spreading out over the brain. That is the corpus callosum. It is the largest, not the only, but the largest fiber bundle that's running between the two hemispheres. And sometimes when we don't remove a specific lesion, we instead try to alter the connections that the seizures use to spread. And the corpus callosum is a common one, and cutting that can be used to treat certain types of seizures. These other diagrams, the middle one is an anatomic specimen. So this is actually a specimen where someone has meticulously removed parts of the surface of the brain to kind of depict the very complicated fibers and highways, if you will, that are running through the brain, including in this case, the corpus callosum. And then on the far right is some imaging technology we have. So luckily, we can now look at these pathways without having to remove someone's brain. But this is basically using an MRI to perform what's called tractography, where we can actually see these connections. And you can see this is sort of a face-on view. all of these pathways. They're colored in different ways because that's how we sort of look at direction when we look at these. Otherwise, it's just so hard to understand. But you can see all of the pathways that are connecting different parts of the brain, which could be potentially targeted to try to disrupt the spread of seizures in the brain. So corpus callosotomy. So again, the corpus callosum is that fiber bundle. And if you ever see otomy in medicine, it basically means to cut. So this is cutting the corpus callosum. This is a very well-established operation for some patients with drug-resistant epilepsy. And it can be performed in multiple ways. On the bottom left is an example of a patient having a craniotomy. So their head is actually, you're looking sort of from the top down on their head. Their head is actually held with a surgical device. And you can see in marker the planned incision line across the head to preserve blood supply and make sure it's all behind the hairline so it can be easily hidden in the future. This operation can sometimes be performed with a smaller exposure. So in the middle picture there, that's looking at a small incision on the top of someone's head, which was used for an endoscopic callosotomy. So sometimes, like we showed in that image, putting in a little scope camera, small instruments, accomplishing it that way. And then on the far right, this is just an example of strategies of where one might place small openings to pass laser fibers into the head for an MRI-guided laser corpus callosotomy. So why do we do it? Well, the main indication for a callosotomy is what's called drop attacks. Okay, so medically refractory drop attacks. These are seizures where a big manifestation of them is like a sudden loss in muscle tone and dropping. Patients can have very injurious falls, and it can be quite debilitating form. And the theory is that the problem is that seizures start somewhere, spread so quickly across the corpus callosum that they affect the motor system of the brain so broadly that it sort of takes it offline altogether. There's like a Control-Alt-Delete reset of the motor system. You lose tone. And then, of course, by the time it comes back, you've already fallen. This operation is still really the best treatment we have for refractory drop attacks. That this series here was published. There are many of them out there from all institutions doing this essentially. But this particular one was comparing doing it with a laser and open. Both work very well. If you do a complete corpus callosotomy, really across centers and techniques, about a 75% chance of elimination of drop attacks is an expected outcome. You see the complication rate there, 6%. One thing this paper was showing is that complication rates from a laser ablation do tend to be lower, and we are increasingly seeing that as more and more publications come out. So what about vagus nerve stimulation? So we talked about, resections. We talked about ablations or lesioning. We talked a bit about sort of disconnective surgeries. But there was a fourth category, which is what we kind of call stimulation or neuromodulation. And the idea here, I sometimes explain it to people saying it's almost like the surgical version of a medication. Okay, we're trying to influence the brain without actually removing the brain or removing, a part of the brain. Vagus nerve stimulation is the oldest of the three options on the market. It is appealing in some ways because it doesn't even involve touching the brain. So in this diagram, you can see that what this does is there is a small electrical stimulator, like a pacemaker. So many people are familiar with cardiac pacemakers, same thing. This connects to a wire, and that wire then gets fed up to the vagus nerve on the left side of the neck, as shown here, and it delivers stimulation to the vagus nerve. The vagus nerve is part of something called the parasympathetic nervous system. We kind of have parts of our nervous system that are not conscious to us. Okay, they're working, but we're not really consciously aware of them. And there is a yin and a yang system for kind of being relaxed, chill, calming down the brain. That's the parasympathetic nervous system. The vagus nerve is part of that. And then there's kind of the fight or flight system. This is like, I'm amped up, I'm ready to go. That's the sympathetic nervous system. The idea here is to activate or stimulate, increase that parasympathetic drive to calm down the nervous system, calm down seizures. So it's inserted with a surgery, typically a day surgery. So you come in, get this put in, watched in hospital for a little while, go home. And it can stimulate day and night, as mentioned here. You can program it, okay, with a little wireless device. It can be programmed to kind of alter itself over time. It can detect your heart rhythm. Some patients will have a spike in their heart rate when they have seizures, and it can deliver extra stimulus in that setting. There's a magnet swipe option, so you can kind of swipe a magnet over the skin, almost like a rescue medication if seizures are clustering or if status epilepticus occurs. These are MRI compatible, as mentioned here, so you can still get scans with them. And it can help some patients. So I think if the next slide talks about outcomes, if my memory serves me correct. Oh, no. Okay, so anyways, with the vagus nerve, we may go back to it, but it can reduce seizures in some patients. It doesn't work for everything. There we go. Sorry. But basically, how efficacious it is. Well, one of the drawbacks, it's both a good and bad. This is someone that doesn't have another option, but about half of patients will experience about a 50% reduction in their seizures. So meaningful reductions in about half of patients. Responsive neurostimulation is the newest form of neuromodulation. This is a system that can be structured in different ways, okay? But basically, it requires that the pacemaker, in this case, is inserted into the skull, okay? So it's put in at the head, and it could be connected to multiple wires, as shown in this diagram. They may target a specific spot in the brain. So let's say your seizures are coming from your language center, and you don't want to remove that, obviously, because that's important to your brain function. Sometimes this can be placed in that area so that when it detects the seizure, it will stimulate it. So it sort of responds. That's the word, responsive, and can stop a seizure without having to remove or eliminate the important function that's in that area. And then the next option is, I think, deep brain stimulation. Well, this is just talking about it some more. So one of the things that's interesting about this and deep brain stimulation is that it takes time. So typically these don't, just like VNS, they don't work right away. You put them in. For this RNS device specifically, it has to learn your brain signals. And once it learns your brain signals, you then start a stimulation sort of programming mode where it now will respond to what it sees. So it does take time. Even for things like VNS and DBS that are not responsive in the same way, one of the things we see is that it can take weeks to months before seizures reduce, and it can take months to years before you reach the maximal effect. When you look at, say, 6 months out, often there's maybe a 40% reduction in seizures. But when you look several years out, there can be a 60, 70% on average reduction in seizures. And, a lot of this we don't quite understand why, but clearly it's interacting with the brain. It's causing some change in the brain, some restructuring of these seizure pathways to make them less likely to occur. These devices require battery replacement, so that's another important thing. No matter which one of these you get, you are looking at, after several years, coming back to hospital to have the device replaced until we have batteries that can last longer. I like the last point here. 93% of parents report improvements in thinking, behavior, school performance. We're getting into a lot of specifics about these here, but I often tell families that, I'm an epilepsy surgeon, but I kind of think of myself more as a brain function optimizing surgeon, a quality of life optimizing surgeon for patients with epilepsy. Really, what this is all about is improving quality of life, improving brain function. We know that children with ongoing epilepsy have what's called encephalopathy, so dysfunction of the brain. We know that the medications we give, unfortunately, cause cognitive effects as well. So the idea is if we can reduce the seizures, reduce the medications, we can enhance brain function and quality of life. And then this is the last one here, deep brain stimulation. This is cool. This is actually a artistic rendition of the first patient I put a deep brain stimulator in. It was not for epilepsy, it was for dystonia, but it's on the web. This was a fantastic family. This was many, many years ago now. But basically, this involves putting small electrodes into a deep target of the brain called the thalamus. And that you can see here that the pacemaker is inserted under the skin in the chest, much like a VNS. And this can deliver stimulation to that target. Again, it's trying to have more broad effect on the brain when there isn't a specific focus that can be targeted. All right. I think that might be the end of the slides, if my memory serves me correctly.
No, that's it. Thank you.
Great.
Do we want to take questions? Looks like we have a few more minutes.
Yeah, I'm happy to. There's some in the chat, I think, but I don't know if uh, I'll try to skim through some chat questions here. I see someone talking about their daughter evaluated by a phase one. So phase one is kind of what we call our initial investigations for epilepsy surgery, non-invasive testing, things like EEGs, video EEG, epilepsy protocol, MRI, sometimes special scans, PET scan, neuropsych evaluation, etc. One thing before I get to the rest of this question that's important to note, and Monika mentioned this, you know, decisions around recommendations for epilepsy surgery, they never come from like me or a neurologist. They come from a group of individuals. I mean, this is basically all I do is epilepsy surgery, but I still don't consider myself qualified to give like a unilateral recommendation. There are so many options. There's so many aspects to a child. The neuropsychologist input is important, the neuroradiologist, the neurologist, neurosurgery. So we come together as a large group to review everything and come up with a consensus that is then communicated to you, either from myself, the neurologist, sometimes multiple people. And you'll find that, that's a similar model, I think, in most major epilepsy programs. But anyways, this says that seizures are firing from multiple places in the brain and is not very localized. So surgery is not an option for us, just VNS, RNS. So yeah, I think that's a common issue. Although, we could, of course, VNS and RNS are surgical options, but cranial surgery may not be an option, resective surgery. And even when that isn't an option, I hope that one of the takeaways from today is that there may still be options that can be of benefit. So I think it's still worthwhile going through the process, learning, educating yourself, and hearing what people have to say. You may still decide it's not right for your child, and that's nothing wrong with that. But I think information, knowledge gives you the power to know what is possible.
If I could just add something.
Yeah.
Some of these with neuromodulation, whether it's VNS, RNS, or DBS, one thing we're talking about is it may not make your seizures or your child's seizures go away completely, but if they're reduced, now you might see a better response to medication that you did not see before. So now the seizure burden is lower. Now they're responding to medication in a better way. So you may then see even more seizures go away because now the medication can treat it effectively.
It's a great point. Moving down here, I've been on medication for 33 years. When I was first diagnosed in 1996, has brain surgery significantly changed? And I would say it absolutely has. I'm old enough to have been in the brain surgery field for that time. And I can tell you that, for example, laser ablation didn't exist at that time. RNS didn't exist at that time. DBS was being in its early days of being used in Parkinson's disease patients, but had not been tried in epilepsy at that time. So I'd say that there have been advances in instrumentation that we use at surgery. A lot of the minimally invasive techniques and equipment has improved. And I would say that, hospital care for these patients has improved. Our ICU care, neurology care has improved as well. So things have changed. Now, that being said, if you're controlled on medication and, that may be great for you, 33 years. But if you're not controlled, then I think it's definitely worth looking into things because things have changed, and some of what may have been scary and less effective in the past is not so relevant anymore. Uh, can surgery help with white matter lesions from NF uh, in a periatrial area? So, um, in general, white matter is the sort of what we call the cables that connect the brain cells, which are sitting predominantly on the surface of the brain, or neurons. Seizures start in neurons, and they can spread through those connections, or white matter. Um, NF is an example of a condition, neurofibromatosis, where there can be small white matter lesions. Um, those are typically not the cause of the seizures. It's typically something else. So I would say that in general, in neurofibromatosis, there can be focal seizures, and it may require some hunting to find the focus, depending on the case. Um, how long is the stay at the hospital? My son is resistant to 3 medications now. We are looking for evaluation. So I think they provided a link in the chat as well to, for example, and obviously there are centers everywhere. I'm not trying to like sell ours, but I think a link at least to ours. I believe through Monica's Epilepsy Surgery Alliance, you probably can easily find links to other centers as well. But absolutely, if you just search through the web, all of the contact information is there. Reach out, and us and other centers, I'm sure, would be happy to evaluate. Hospital stays will vary, of course, depending on the treatment. It can vary from, just a few hours, say from a VNS surgery to, let's say your child is getting invasive monitoring, something called stereo EEG, where we put electrodes into the brain temporarily to localize seizures, and then do another surgery afterwards. You may be in hospital for a couple of weeks. So it's really specific to your treatment pattern. And I would say that, you know, you got to start at the beginning. All of the basics are important. The neurology evaluation, the basic workup to understand what may be relevant, and then discussions with people like me about what it would be like. Discussions with coaches and contacts through resources such as the Epilepsy Surgery Alliance. Instead of hearing from me, talk to someone who's actually had surgery, or a family who's gone through it. So there's a lot to go through at the beginning, but obviously we totally understand. I mean, these things can be scary propositions. This was so helpful. My 14-year-old daughter is scheduled for an awake craniotomy in June. Has an FCD near eloquent cortex. Fingers crossed. Well, uh, uh, fingers crossed is okay, although I like to take luck out of the equation as much as possible. So best of luck to them. I don't know if I'm doing it, but if I am, I'm sorry. No, I'm just kidding. But best of luck to you, and you have every reason to be very hopeful. Are any of these appropriate for generalized epilepsy? And if so, how effective? That's a great question. So absolutely yes. So for generalized epilepsy, that's a term we used for seizures coming from very broad regions of the brain, not a specific focus, sometimes maybe even kind of the entire brain. And that's exactly where, for example, deep brain stimulation or RNS can be placed in parts of the brain to have broad effect, VNS. There are certain forms of generalized epilepsy for which a callosotomy can be helpful. So there are actually modalities that may be applicable to generalized epilepsy. So I would say generalized seizures is not, and this is kind of a way doctors used to think this way, but it's generalized. Okay, medications, good luck. It's absolutely not true right now. Thank you for your time, Dr. Enjoy. Oh, that's very kind of you. My pleasure. Thank you.
We tell families every child with drug-resistant epilepsy is a candidate for some type of epilepsy surgery. It's just which one. There are very few who would not be, for example, candidates for vagus nerve stimulation. But all of these procedures, it's a huge menu of options that it's your right as a parent to know about, to understand. And there are really very few situations where there wouldn't be some procedure that might help.
Um, just needed to say thank you. I wasn't born with epilepsy, but I did get it after my daughter was born. And obviously the focus of this is pediatric epilepsy. We believe treating children as early as possible when appropriate to maximize their potential for future developmental gains and maximize, the lifespan that they live with improved quality of life and lower risk of sudden death, et cetera, is important. But there is a whole world of adult epilepsy surgery out there, if I'm reading this correctly. So certainly there are wonderful adult centers as well. I was wondering if you have experience with VNS, RNS, or DBS for DEE-SWAS. I'd have to get a little help on what that acronym is here. Our daughter actually already had a left anatomical hemispherectomy, but developed, I'm guessing, persistent seizures and also needs medication for seizure control within the last year. The research is limited and even more so in her rare condition. So it's probably so limited that if I heard the full, do you know the full thing, Monika?
Well, I'm an anatomical hemispherectomy mom on the third attempt. So my son had an anatomical on the third attempt, a third surgery. And I would say to that parent, I can't see the question. So the first thing is make sure your child actually had a true anatomical hemispherectomy. Often the surgeons will say they performed an anatomical hemispherectomy, but they leave behind a couple of pieces. Sometimes they leave behind a big part of the brain called the insula. And I've seen this a lot. I've been in this community for 19 years, and we see this a lot where, oh, the surgeon said, not to bash any surgeons here, they said they did an anatomical, and you look at the MRI and, oh, but look, there's a little piece that they left behind here. If they truly had an anatomical hemispherectomy, then there is a possibility that that other side of the brain is starting to have seizures. Typically, we see this with my son's condition, hemimegalencephaly. And so they can now put an RNS device in the healthy hemisphere that's starting to have issues. We have 4 or 5 kids now that I know firsthand that have an RNS in the remaining hemisphere. My son is now having what we're calling like a firing in the healthy hemisphere. It's spiking, not quite seizing in 2 parts of the brain. So we're just waiting to see if maybe, once those do become seizures, hopefully they won't, if an RNS would be appropriate there.
Thank you, Monika. That gave me time
Hi,
to Google.
Haley. I see you in the chat. Yeah.
Yeah.
No, I appreciate it. But yes, we
Yeah.
we crossed that bridge. Thankfully got 3 reassurances.
Okay. Then I would explore an RNS device for sure.
That's where I've been leaning, but I mean, I'm not a neurosurgeon, so I don't know. So I've just been kind of pursuing looking at all 3.
Mm-hmm.
Yeah, and I just looked up the DEE-SWAS. So I am familiar with the developmental epileptic encephalopathy and then the SWAS is referring to an EEG pattern. But I agree with what Monika said. I mean, I think it sounds like you've already done your due diligence to ensure that the hemispherectomy was done appropriately. But now what you're dealing with, I do think that neuromodulation in the form of, RNS, thalamic neuromodulation, and even VNS will be considerations. Certainly something that would need a multidisciplinary discussion to review. We are in the middle of phase 1. Does phase 2 always require SEEG? So yeah, phase 2 is our kind of term for invasive monitoring. So it's not a therapeutic surgery. It's not a treatment surgery. It's a diagnostic surgery where we implant electrodes into the brain, either with stereo EEG, which is where we put a bunch of small little electrodes into the brain through small stab incisions, a bit like those laser fibers, or with a craniotomy for placement of what we call subdural grids, where we kind of put a blanket of electrodes on the brain. The stereo EEG has by far become more popular because it's much less invasive. So that's what a phase 2 refers to nowadays. It's almost synonymous with stereo EEG. What if enough data isn't collected to figure out where or why seizures are happening. Currently, all imaging has been inclusive, but EEG and MEG show some focal area of temporal lobe seizure activity. The whole team seems stumped. So, yeah, I mean, I think it sounds like a good example of when we consider invasive monitoring in the form of a stereo EEG or a phase 2, when we cannot non-invasively pin things down enough, but we do have reason to believe there is going to be a focal source, then we need to hunt for it more specifically. And, stereo EEG is the best method we have to pin things down because it is directly recording from the brain. It is invasive. It does have some risk. It is something to go through. So, not everybody is appropriate for stereo EEG, but it does sound like it's appropriate. And, typically, if it's planned carefully, it will give the answers required to guide subsequent therapeutic surgical steps. But, there's always a small risk that, let's say, you get surprised and seizures appear to be coming from an area that you didn't put as many electrodes in as you ideally would like, and you may need to put more in or consider repeat. So there can be a journey, but it does sound like that would be appropriate in a situation like that. Is that typically an indication of cortical dysplasias? I think that's a follow-up, yes, to the same question. Yes, you can have types of dysplasia in the brain that are just really difficult to see on an MRI, even with the latest and greatest MRI scanners. So it may be so kind of microscopic that we just can't see it. What are the biggest factors that go into deciding what procedure is the best / will be most effective? So I think that this is a hard one for me to answer just off the cuff here, because it really does require, in my mind, a multidisciplinary discussion. As I was saying before, I have never and I will never recommend a surgical treatment for epilepsy without a multidisciplinary discussion. And I live, eat, breathe, and sleep this professionally all the time. And one of, if not the busiest pediatric epilepsy surgeons in the country. It's just, this is a complicated thing. I think it requires a lot of input from a lot of people. I'm not a neurologist. I need to have these discussions. I look at things through a certain lens as a surgeon. Other people look at things differently. And I think all of those inputs are important. We're dealing with really, really important decisions here for children that are going to affect the future of their lives. And we want to make the right one because there is that potential to really help. Surgery does have risk, and I certainly don't want to hide from that today in this discussion. So you want to really be careful and make the right decision. And the only way in my mind to do that is to get all of the inputs to make sure that goals are aligned. All of the facts are on the table, and we've done everything we can to understand it before we subject your child to any risk. What questions should we be asking if exploring surgery and doing the phase 1 testing has been recommended? Well, I think, when you're at the beginning, it is fair to ask questions like, do you think there is a focal source for the seizures? What makes you think that surgical evaluation is useful? What do you think the possible outcomes might be? And you may get kind of vague answers because honestly, that may be the best that can be done. But I think, asking questions at every step along this journey is important. As more information comes in, the picture becomes clearer. And the more time you have to process all of these various things, the better you're going to feel about your final decision. Another thing is, it's complicated. I mean, I am a big proponent in multiple opinions. If people feel that's helpful, you shouldn't just take it from one. I tell people when we want to get our house painted, we get multiple quotes, this is a pretty important thing, arguably more important than getting your house painted. So, there's nothing reasonable or nothing wrong with getting multiple opinions. I certainly have never, as a surgeon, felt offended in any way by someone saying, I think we want to get another opinion. My answer is, great, I can help you if you like. You can do it yourself. I know people I can refer you to, recommend. You want to ask questions and you want to feel comfortable that you've explored whatever you need to get to that point where you feel comfortable making a decision.
Absolutely. Dr. Stone, thank you so
Yes.
much for being here tonight and for spending your vacation time with us tonight. And Monika, thank you so much for partnering with us with the Pediatric Epilepsy Surgery Alliance. We can't thank you both for spending your time with us tonight and spending your Wednesday night with us and being able to help our families. We will be sending the recording out from tonight's webinar to everybody that was on the call tonight and everybody else who had registered. We will also be making sure that all of the resources that were in the chat tonight are being sent to all the families that have been registered for tonight's webinar. So everything that was in the chat will be sent to everybody that was on the call tonight, so on the webinar tonight, so that everybody will have those resources. So we want to thank everybody again for being here tonight. And thanks again, Monika, for joining us. We truly appreciate your help and your resources that you provide to our families. And thank you, Dr. Stone, again, for always being part of Epilepsy Foundation New England's family. We can't thank you enough for everything you do for our families.
Thank you so much for having us.
Wonderful. Have a wonderful evening, everybody.
Thank you, everyone. Take care.
You too.